Hi, my name is Sheehy. I'm a perioperative medicine fellow at UCLH, and I'd like to present a review of intrathecal opioid policies across the UK and the Republic of Ireland. For a little bit of background, intrathecal opioids are used regularly in our surgical population. However, we have noticed a wide range of doses being used and have noted a lack of standardized guidance in the literature. Concerns exist surrounding potential side effects, in particular respiratory depression. Increased monitoring is suggested for patients who have received higher doses. However, the cutoff for this is unclear. With increased pressure on our enhanced care beds, we wish to ensure that they are used appropriately. The aim of our project was to see how hospital policies across the UK and Ireland compare with regards to doses advised and post-operative monitoring requirements. We contacted anaesthesia departments across the UK and the Republic of Ireland. 25 responses were received, of which 15 had policies available, 10 did not. We analysed the data regarding opioid selection, dosing guidelines, enhanced care thresholds, and post-operative monitoring. Of the 15 policies, 10 of them gave dosing recommendations with regards to intrathecal morphine, and 8 gave dosing recommendations with regards to intrathecal diamorphine. The morphine doses that were suggested ranged from 50 to 100 micrograms up to 750 micrograms. The diamorphine doses that were suggested ranged from 100 to 400 micrograms up to 1500 micrograms. The types of surgery were not specified within the policies, but they were all non-obstetrics. This wide range of recommended doses would suggest a lack of standardization of dosing. Another finding was that the threshold to require an enhanced care bed varied significantly among the policies. 300 micrograms of morphine was the most commonly cited cutoff, but it stretched up to 500 micrograms in 2 hospitals and as low as 150 micrograms in 1 hospital. Similarly, the cutoff for intrathecal diamorphine varied between 200 micrograms up to 1500 micrograms. In terms of postoperative monitoring, 11 of the 15 policies gave specific recommendations. Most suggested hourly to 2-hourly oxygen saturation monitoring for 24 hours following intrathecal morphine. Some policies allowed for a more liberal monitoring strategy following intrathecal diamorphine. To conclude, recent systematic reviews suggest that lower doses may be required than what is being used on the ground. However, as there is such a gap, is further research required to robustly guide our practice. Going forward, we plan to do a retrospective review of rates of respiratory depression in our hospital. We also plan to update local guidelines to ensure that appropriate dosing is being used and to allow for the best use of our enhanced care beds. Following all of this, our next question is, should there be clearer national or international guidelines when such a variety in practice exists? Thanks for listening.